Paul is a registered nurse who provided care to patients as the unit manager for the Neurological Rehabilitation Program for Southern Alberta. He is currently the Calgary Zone Director for Patient and Family-Centered Care, Patient Safety, and Clinical Quality Improvement. Paul has a strong passion for patient and family advocacy and has chaired and fostered patient and family-centered care across Alberta and is currently leading the End PJ Paralysis campaign to support patients around respect and dignity and to avoid deconditioning while in hospital. Before we get started, I'd like to let you know how to engage with Paul today. Please type any questions you have for him in the chat box, and we'll have time for him to answer at the end of the presentation. I'll start by answering the most commonly asked question: can we have a copy of the recording for this webinar? Yes, you can. We'll send them to attendees and post it on our website and YouTube channel. And with that, I'd like to invite Paul to take the stage.
Thanks so much. I'm just going to pull up my slides here for the group this morning, or this afternoon. Sorry, it's morning where I am here in Alberta. Just bear with me for a second. Okay, I just wanted to confirm that you can see my slides okay. Perfect. Okay. So I'm going to talk to you a little bit today about End PJ Paralysis work, the generalities of PJ Paralysis, as well as the Alberta context, how we got started, what we did to kind of launch our initiative off the ground, our outcomes to date, and some of our lessons learned within the program that we've got started. So first off, End PJ paralysis is really a unique, fun term to describe the negative and physical and psychological conditions experienced by patients who spend lengthy periods of time in bed or inactive in their pajamas in the hospital. And here in Alberta, we focus a lot on the hospital gown, so you might hear me focus a little bit more on that. People on lengthy stays can lose muscle strength, which leads to longer hospital stays. And wearing only pajamas or hospital gowns can also make a person feel less human, more vulnerable, and constantly remind them that they're ill. I'm very much a student of End PJ paralysis. The movement has started with a close friend and colleague, registered nurse and Professor Brian Dolan from the United Kingdom. He also works with the National Health Service, and he has his own company called Health 360. So Brian has been an inspiration to many of us and is one of the main reasons why I'm here today to speak with you. So let's get down to the gist of End PJ paralysis. And I like to talk about some of the negative pieces, but also sell it in a way that we can understand how deconditioning can really impact patients and families. So if you spend 1 week in bed, and these stats are specific to people over the age of 65, so it's our senior population, but I want to just to outline that PJ paralysis very much is important for all of our patients, age groups, conditions as well. So if you spend a week in bed on bed rest, that we'll make sure that you lose up to 20% off your total muscle power of your quads. And we know that our quads are used for strong ambulation. They're a mainstay for helping support balance as well as getting up and initiating that movement out of bed. We also know that we're going to lose 10% off our aerobic capacity. So things like having hospital-acquired pneumonias are something that we need to look at as well. Some of my colleagues would even go as far as to say that losing that 10% off your aerobic capacity is very much similar to the effects of smoking a pack of cigarettes a day. So I just wanted to share that with the group. When you look at other stats specific to deconditioning, there's a whole host of them here on the screen, but I'd like to highlight a few specifically. So one that really resonates with me is that we have a 48% increase in the chance of needing help with activities of daily living 1 month after discharge. And that's not just after discharge, that's 1 month. So we know that our patients are losing some of their ability to manage their own personal activities of daily living. As well, and in Canada, we know we have a challenge with placing patients in appropriate bed spaces. So if we look at how patients are being deconditioned in a hospital environment, we have 5 times the risk of needing institutional care on discharge. So what can we do to prevent our patients from needing that external or extra support when they're going home? Can we really look at how we can focus on keeping them strong so that they can avoid potentially needing a secondary institution to support them at home? Can we look till we get them home safely with supports and potentially avoid a transition to another care space? But we're still not done. So that's another key piece. And this is why I think one of the things that's been important in Alberta Health Services for us is NPJ paralysis checks a lot of boxes, especially when you look at some of these key indicators and the key things that happen to patients in the hospital. So we also know hospital inactivity is associated with accelerated bone loss, malnutrition, delirium, pressure injury ulcers, which we know is one of the main expenses to the health system for secondary outcomes that can be completely avoidable for patients. We have also know that blood clots or venous thrombosis embolisms in the new terminology are also associated with hospital inactivity, and for sure patient falls. We know that when patients are getting weaker, they're not in their own environment, and they tend to have a greater chance for falls as well. So that's a bit of a background about the whole End PJ paralysis and why our group got really excited to be involved with it. But I want to shift our focus now to the Alberta context and share with you a little bit about our health system, how we got started, and why we even began this journey. So Alberta Health Services is Canada's first and largest province-wide, fully integrated health system, and we're responsible for delivering health services to over 4 million people living in Alberta, as well as some residents in Saskatchewan, BC, and the Northwest Territories. We have 106 acute care hospitals, 5 standalone psychiatric facilities, and we roughly have about 8,500 acute care beds and about 24,000 continuing care bed spaces within our authority that we work with. Specifically to my role, I'm showing you a picture now within the Calgary zone. So these are the barriers, or these are the boundaries that I get to work in on a daily basis. So you see in the large boxes, those are the 5 urban centers that typically provide the bulk of care within the Calgary area. We have our children's hospital and 4 adult acute sites that have their own primary specialties as well that they're broken into. You can see throughout the scattered map that we also have 8 other rural facilities that we support and try to mentor and help with quality improvement in activities such as End PJ Paralysis. So I wanted to give you a bit of a background to what our context looks like. And I know in the Ontario setting, we used to refer to it as the local integrated health networks. I know that is changing or has changed, but our zones are very much made up and are comprised of the same way. So why did we get started with End PJ paralysis? And I wanted to ground us all for a few minutes here. We actually had received a very significant patient concern. One of our patients in one of our urban hospitals was up walking with a colleague, a health provider, and wearing a hospital gown. And whether it was an open door or a shift in ventilation, but unfortunately this lady was exposed to the public because her gown was open at the end, and it was a very unfortunate experience. So we got pushed and to really make a big change. Understand, why was the lady wearing a hospital gown? Is there a reason why we couldn't have provided clothes? And it made us think about, wow, we actually don't have an overarching policy about the appropriate attire for patients. And we thought, you know what, we don't need one, but we need to do something about this to encourage patients and families to bring in their own clothing. So we dug a bit deeper. So we took a few first steps. And what we did is we looked, what's happening out there in the world. And that led us to Brian Dolan, which you can see here on the screen. So on April 3rd, 2018, about a year and a half ago, Brian came to Calgary and presented how to make patient time the most important currency in healthcare. And one of those initiatives that Brian spoke to us about was End PJ Paralysis. Brian, I think if you've heard him before, he's a very passionate, articulate speaker, and he leaves you with that message that you want to make a difference. And he certainly left that impression with us. We were able to use technology and show Brian's presentation across 20 sites within Alberta Health Services as well, which was great to spread and scale. And that was kind of the first piece of our taste of becoming engaged in the End PJ Paralysis initiative. So from then on, since I invited Brian to speak to us, I became the de facto leader for End PJ Paralysis. And at the time, I had no understanding of how important this initiative would become for our patients and families and our healthcare providers as well. So people wanted to know, what are we going to do, Paul? How are we going to make this happen? So we mobilized, and on May 1st, so just less than 1 month after Brian came to speak with us, we engaged a whole host of people, frontline staff, patients, families, and we did a half-day session, which I call tri-storming. Anyone that's done kind of a Kaizen or a Lean Six Sigma approach for quality improvement might know that terminology, but it's really just trying and doing at the same time. So we had breakout groups, and we wanted to think about, what is the engagement and marketing plan we need to do, and how can we be a bit different when we do that? What are the education and resources that patients and families and specifically frontline staff are going to need to be able to mobilize and understand and help own this interaction? And how are we going to measure and evaluate? And I think that's something that we talk a lot about in healthcare, and at times we struggle with it. So it was key to understand what those pieces might be upfront, what we're already measuring, so we don't have to ask staff to do duplication, and how can we use that to really drive quality improvement. So if we're going to collect the data, let's make sure that we're going to use that data. Here's just a quick snapshot of that engagement group. I'm wearing my wife's bathrobe in the front there, and why we chose to have some of us in pajamas was just to make that initial statement. And I want to be honest with you, when I was walking around one of our hospitals where the event took place, it was quite intimidating to wear pajamas. I felt kind of out of sorts, so it was actually a unique thing to do. And some of our teams have actually done PJ days at their launch just to raise awareness with patients and families as well. So from that day forwards, we really coined the phrase, say goodnight to hospital gowns, get up, get dressed, get moving. And that was kind of our overarching theme, is to focus not so much on PJs, but the hospital gown itself. So that's a slightly different take than what we've done with our colleagues in the United Kingdom. Our focus, we know that patients don't like the hospital gown. Some do, but for the majority don't. And I'll talk a little bit about it in a minute. We knew that pajamas for the most part, and I'm in that same box. I love putting on my sweatpants and sweatshirt when I get home from work, but I still am able to do my activities and be functional. So we wanted to break that kind of myth that wearing your own clothing, such as sweats and things, shouldn't be allowed, but absolutely we wanted to focus on that and really break that myth about hospital gowns itself. So one key thing, and what you're seeing here, is just one of our priorities for the Calgary zone. So sponsorship is absolutely key, but the most important thing is that you have that sponsorship, but that you have a co-design with patient staff to be able to do the essential work to drive the change, to understand what the limits and challenges might be. So for our group, we're very fortunate that we got permission early on to go out and do this and try it. Permission to fail safely, but also permission to be bold and to do things a bit differently. So for us in Calgary and in Alberta, we really focused on two key aspects of End PJ Paralysis, and that's respect and dignity and deconditioning. And I'll break those down for you here in a second. So that respect and dignity piece really started with that patient concern. So how did we, potentially take away that dignity from the patient that was exposed in our healthcare system? So it really started with that patient concern. We know that patients tell us from time to time that they feel the hospital gown doesn't allow them to be themselves, that they feel institutionalized, and at times that they can't question their healthcare team. And even that it kind of keeps them in bed to the point where they don't feel comfortable to get up and move around. So it's that self of lost control, and even it provides a decrease in self-identity. A lot of people like to express themselves with the clothing they wear, and I'm the same as well. So we wanted to understand that respect and dignity is a key piece to this, and it's not only just about deconditioning, but it's about both. So deconditioning, as I mentioned, is the second key piece that Alberta Health Services is looking at for End PJ paralysis. And we know that hospital environments limit mobility, and I often call it bedcentricity, where the bulk of the care is provided at the bedside. And myself, as a registered nurse, my practice was quite often to tell patients to go back to the bed, wait for their meds, wait for their rounds, wait for the physicians or the treatment. So it's kind of our culture that care is in the bed or at the bedside. So it is something that we need to be mindful of when we're rolling things out. How can we break some of those stigmas or those pieces that have been culture for so long to get patients up and moving? A lot of our medical pathways are focused on actual specific interventions, and they actually have leaned away from things such as getting patients up and mobilizing. So it's really a challenge from a nursing perspective, if your order set is activity is tolerated, but you have a whole bunch of other priorities. Really, that activity is tolerated is seen, the patient can do what they want, but the focus is less on getting up and moving. So, looking at how we provide order sets and even medical pathways can really help with the focus on deconditioning. So here's a study I wanted to share with you. It's actually just a news article about a study, and some of you might have been in this study. Researchers looked through Montreal and Toronto. They surveyed patients across 5 hospitals, and they outlined that about 60% of patients would have loved to have worn their own clothing when hospital, and about 10% of patients were invited or honored or welcome to. So this started us thinking about some of the metrics and numbers we should be looking at it and going for. And I love their cheeky aspect of the dreaded hospital gown, described as healthcare's prison jumpsuit, often imposed on patients needlessly. So I know that's a bit cheeky, but at times I think that's kind of a statement that I like to put forward to a lot of our colleagues, patients, and families as well. So we wanted to look at, okay, we know what's happening in some of these other centers, but what about our own backyard? So I reached out to one of my close colleagues, Dr. Sean Duclo, and Sean is a stroke physiatrist. And what Sean did when he was looking at the stroke best practice recommendations in 2013, he wanted to understand, what was the intensity of rehab that patients were getting? Were they getting that full hour of physio, occupational therapy, speech, and others? But also what Sean looked at was what patients were doing on their off hours. And I wanted to quickly highlight. So this is my old program, which is the neuro rehab program for Southern Alberta. And we've been recognized, I think, 5 straight times now for the Stroke Distinction Award from Accreditation Canada for excellence. So I always prided myself on, we were one of the leading edge units of providing this cutting edge rehabilitation for our stroke patients. But when you looked at some of our measures that Sean had showed, it was actually quite shocking. So if you look at the first blue arrows on the left-hand side, around active pursuits of exercise and walking, patients are spending less than 10% of their time during their waking hours doing those activities. But if you look at the far right around inactive, so things like watching TV, sleeping, and doing nothing, we're almost about half of their time of not being engaged. So this is something I wanted to let everyone know, specifically in our area, but also across the province and across the country, that even in those active care settings where you feel that patients are getting enough stimulation and enough activity, that oftentimes they aren't. So it's really important to take a look at what we can do with patients in their off hours, outside of physio, some of those nursing interventions, occupational therapy as well. So I wanted to shift the focus from understanding where our background came from to approach this work in Alberta Health Service to kind of how we got things off the ground and outside that tribe-storming session. So for me, working in patient family-centered care, it's absolutely pivotal that we look at the power of engagement, not only of patients and families, but our frontline teams as well. They're going to be the ones that are going to either sink or swim this initiative, and it's important to engage with what they wanted to know. So first thing off the bat, I called some colleagues across the province and said, hey, I think we got a big ticket item here. I think we can do a lot of good. What are your thoughts on getting a community to practice together? So we connected all 5 zones in Alberta Health Services, which is just a picture there on the right-hand side of our makeup, using some of our technologies such as Skype, which is very similar to the platform we're using today. It allowed us to spread and scale some of our work out to the local context, and created a zone-based champions to share the work and help with messaging. So allowed our patient-centered champions and also key leaders across the zones to spread and scale and to kind of get that local engagement starting. It put End PJ Paralysis on the leadership radar. And what I mean by that, our community practice grew so quickly in a matter of a couple of months that our provincial organizations started to support some of the messaging around our communication plan, our branding, how we collect and design our data, and even a new web-based design as well. So it was wonderful to start that precedent of getting the initiative going at the grassroots, and then being recognized for the potential and the great work that's happening and spreading and scaling across. So typically in most organizations, you see it the other way. You need endorsement, you need supports, and then you kind of roll it out with a targeted or a scripted approach. But we kind of did it backwards with this initiative, and I think that's been a huge part to the success. For me, in my background, I had rolled out initiatives that I didn't get feedback from frontline teams, and to be honest, those are some of the hardest ones to move forward. So it was critical that up front, I shared with the frontline nursing and allied health teams that we're going to be implementing this work, what End PJ paralysis was, and what were those concerns that they have or that might be impacting them to provide their care. So right out of the gate, we met with 4 teams and we asked them, just that question, what were those things that you're worried about? And we came back with a big 5 and later 5.5 concerns. And I'm going to share those with you now. Actually, I'm going to get you to do a bit of a poll for me. So I'm going to pass it back to the group. So your poll is there on your screen if you're open to, and it's anonymous. We can't see who votes where, but please feel free to vote and let us know what your thoughts would be. So we'll take about another 10, 15 seconds. It would be great to do that. Perfect. And if we could potentially show the results, that would be wonderful. So the group came up with staff time and resources, and absolutely that was a concern. And actually, this was a trick question. So all of the concerns from patients, or all of the concerns from frontline staff, were almost equally as weighted. But the big one that came back were actually staff expectations on laundry. Staff were really worried, and again, without having some further background, that they were going to have to now be the housekeeper for patients and do their laundry and try to figure out how they can make that happen in their daily work. So right up front, I wanted to blow this myth up and outline that staff were not expected to do laundry for patients. Those areas that did have laundry, such as rehab or mental health units, that is part of their care plan. But those areas and probably a bulk of our units in Alberta Health Services don't have washing facilities, even at a site base. So we needed to understand that partnering with families or friends was going to be a huge part to this initiative. The other aspect that we wanted to look at, and most frontline care providers are always concerned about, okay, how is this going to impact infection prevention and control? What are those things we need to do to mitigate that? So we wanted to understand that following the policy and procedure laid out by our infection prevention control colleagues is absolutely key, and we should not sway from that. But at the same time, regardless if you're wearing a tuxedo or a hospital gown, those principles should not change. You still have to adhere to hand washing, personal hygiene, those things when patients are on isolation for MRSA and VRE. We still have to be mindful and follow those principles, but it shouldn't impact the ability to have patients wearing their own clothes. The next piece is, what about those who don't have clothing to wear? And this is really important to think about. A couple of our hospitals are seen as urban inner city hospitals that really support the low social economic status. So some of our patients don't have clothing. They might be, choose to live at risk and be in the homeless situation. So how can we provide them any supportive resources such as clothing to make them be a part or want to be a part of this initiative as well? So being a part of a large organization, we supported and worked with our volunteer resources team. They actually have clothing cupboards at all of our sites where they have brand new clothing items, personal hygiene items, things like razors, shampoos, things like that to help patients typically at discharge. But we wanted to see if they would be open to partnering, and they absolutely have been a wonderful partner to make this happen for us to avoid any challenges that we might have. Diagnostic imaging is one thing I wanted to speak about, and this is one of those times that it is important to have a patient in a hospital gown for a couple different reasons. One is that we don't want to overexpose patients to any unnecessary radiation that they might have by taking repeated tests. So throughout this work, I found out some unique things, such as Lululemon pants, for example. The logo actually has metallic pieces that can't be used in MR machines. A lot of pants have hidden rivets or things that can impact the clarity and quality of X-rays, CTs, and MRs. So we worked with DI, and we wanted to understand their concerns, and we wanted to be open with ours. And we came to the conclusion that the best approach is just to be transparent with patients, to say, hey, Paul, at 2 o'clock today, you're going to go down for your CT scan. We want to let you know that you're welcome to be in your clothes, but we're going to have to change back into a hospital gown and just have that conversation. But if it is a barrier, really still focus on getting patients up and moving as much as you can. Staff time and resources is very important, and as all of you on the call today, or the majority of you, had outlined that was one of your big concerns, and absolutely it was for our staff as well. We wanted to highlight a few pieces. So thinking about using synergy in a way of providing care. So if you're working with an allied health colleague, let's look at how we can provide some co-treats. If a patient gets up to the bathroom, let's kind of encourage them to take a few extra steps, walk out to the hallway, walk to the nursing station, walk down to a social area, and get those extra steps. Even things like, how do we use bedpans and urinals? Are they always needed in certain settings? Can we encourage patients to and this is kind of a funny term, but to end urinal paralysis. So getting patients up and not using the urinal. So small tips and tricks. And, we really wanted to reiterate that staff time is incredibly valuable. And in our organization, we have so many competing priorities. So our goal is not to create this new practice that's going to change how they provide care, but to really add on to those opportunities where they can encourage patients to take those extra steps as well. And one of the last pieces that staff really brought forward, patients that are formed under the Mental Health Act or a high risk for elopement. And in our acute care facilities, the practice is really not standardized. So for this piece, I really wanted to not be prescriptive, and I wanted to understand what the current practice was on those units. So when you have a policy around our mental health patients that state that patients should be in their hospital gown due for recognition, we have to follow that policy. But for those areas that don't have that approach, understanding how we support it with our medical team, document it, and take a safe approach with that. I also like to push back on this one a little bit as well. Many of our care environments in the long-term care setting do manage patients that are high risk for elopement or are in a dementia care unit, and they do get patients up in their clothes. So there are reasons to have patients in a hospital gown for the most part, but we wanted to look at how we can change that culture. And so these are some of the big risks or big thoughts of our nursing and frontline teams that they had. But if you reflect on those concerns, the majority of them are around clothing, which was really interesting to me. And I think it goes back to that culture piece of how patients or how even staff interact with patients, getting them in a hospital gown right on admission, but really, that's how we've always done things. So I can understand why the concerns are really about clothing. And I also wanted to make sure to our staff that if there is no options to get patients dressed, then still really focus on that deconditioning piece, still support patients to get up and move as much as possible, and use a harm reduction approach with them. Share some of those stats that I shared with you at the start of the presentation. Talk about what is really important around that deconditioning piece. So never let clothing be a barrier when it comes to End PJ paralysis. It's one piece, but it's not the only piece, and we know there's still a lot of beneficial health outcomes. When we were looking at engagement, it was really critical to understand what are patients' thoughts about this? How can we help them understand? And not only patients, but caregivers. So you're seeing a one half of a pamphlet that we designed, and it was actually designed solely by patients and families with some support from our little team within Patient Family Centered Care. But we wanted them to teach themselves and to teach others around their lived experience and what they could do a little bit differently. So that was a unique approach. I think a lot of health systems, think about what patients might want and they put it down on paper and they ground it in evidence and research, but they forget to ask patients actually what they want to know or what this means to them. So it was kind of a different way to approach this. When we were embarking on that journey, one of our patient advisors, Dick Oliver is his name, he actually said, you know what, Paul, I just had my knee done about a year ago, and I wish someone would have told me a couple of things about, being in the hospital. I had brought some khaki pants, and I didn't realize how many times I'd be asked to take my pants off to assess my knee. I wish someone would have told me, please bring in shorts. It would be so much easier. And that got us thinking. And then a whole bunch of our other patients started talking about, yeah, that would have been great if I did that, and if this happened. So we created a document from words of wisdom from one patient to another. And this has probably been our most successful educational tool to teach patients around some tips and tricks to end PJ paralysis. So I wanted just to highlight the power that patients can bring to initiatives like End PJ paralysis. We also got creative and used some marketing tools. So actually the gentleman, Dick, I was talking about is shown on the left-hand side on the large cardboard cutout. So these actually stood outside of the elevators of our first pilot units and allowed for public awareness and some branding as well, to the point where, although it was only on 2 units or 2 floors of a hospital, patients and families that saw these would get off the elevator and go back to their unit and say, hey, like, can we actually really bring in clothing for our loved ones, or am I actually okay to wear, what I want to wear, as long as I'm not impacting, any of the clinical treatments? And it actually allowed for a huge spread in scale. So things like branding and marketing, I think, are still pretty new in healthcare, but there's a lot of power and a lot of understanding of how that can spread. And I'll share a data slide with you a little bit later that shows that's what we're seeing here in Alberta. But you're probably thinking, this sounds great, but what are the outcomes? That principle, it sounds cool, and yeah, patients can get behind it, and staff, they could probably make it work too, but how are you doing, and are you seeing any outcomes? That's always the big question. So our goal in the Calgary zone was to have 60% of patients up and dressed and moving before 11 a.m. And that is the same goal that the National Health Service had with their 70-day challenge back about 8 months ago. So we wanted to do the same metrics so we can correlate and look at the data with the NHS and see how we're doing, benchmark ourselves against them as well. So using that data in a robust way. So what we did, and we're very fortunate in our organization, we have a survey software. It's called Tableau. But Tableau actually allows us to post publicly for any NHS employee to see how teams are doing. So this is one of the interfaces that we created for End PJ Paralysis. And I'll break down the pieces a little bit more for you so you can see them a bit clearer. So as I shared, our goal was to get 60%, at least 60% of patients up and dressed. And that was similar to the rates in the UK, but also to that study that I showed you at the start of the presentation. So we knew there was about 60% of patients. So throughout our kind of about 9-month journey now in the Calgary zone, we've come from anywhere from 58 to about 65% of patients up and dressed before 11 a.m. And this stat is as of August 13th, so just about a week ago. And we know that this isn't for everybody, so we've made this a patient choice. And we've had about 13 to about 16% of patients decline to get dressed throughout the project. And we also knew that clothing could potentially be a barrier, or even post-op surgery patients might not have the clothing or want to put the clothing on. So we knew that being mobilized, there was a little bit higher number of patients being mobilized, and still a number of patients declining to mobilize as well. And again, this is something that we wanted to reinforce, take that harm reduction approach with patients. So not being authoritarian, but letting them know the importance of it and having them choose if this is something they want to be involved in. So for those pilot units, and this is a busy slide, so I don't want you to focus too much on the colors, but this is our dressed and mobilization rate trends throughout kind of our journey, about 8-month journey. So it allowed me as kind of the facilitator or supporter of this work to see how my unit teams were doing. So we set it up with a statistical process control chart, which just allows us to see how the teams are doing on a consistent basis. Are they above the curve, or are they below the curve? Or are they kind of sitting within the gray zone? And it also allowed us uniquely to say, okay, there's a couple teams that historically started low, but then just kind of peaked and went off. So what happened at that intervention? And that blue line, actually, the one that's above the curve for the most part, we investigated that, and we found why they had such sustainability is they shift that focus of accountability from one charge nurse or a unit manager to the healthcare aides now owning and taking charge of End PJ paralysis, and even documenting and sharing it within their care team. So that was a real eye-opener for us and allowed us to see how even a visual representation of data can understand the importance of one small change in a pilot. This is actually the mobilization rate, and you can see teams have done well with this. They've stayed above the goal and consistently and continue to do so. So that's wonderful for us to see and to track that as well. I'm a big fan of competition, and I think it's really healthy in a fun way. So what I wanted to do was create a leaderboard for our zone teams to see, hey, how are you doing? Your Rocky View units or your Foothills units are two of our hospitals. Looks like one unit's doing better than the other. So I'm going to tap on that manager's door and say, hey, you're getting beat. What are you going to do to make this better, and have that healthy competition? So it's been really unique to use this leaderboard snapshot in a way that provides that competition, but also shows me as a zone leader how our teams are doing and where I need to help to with some supports. But what are we seeing? And we've been measuring length of stay. So some of you might be aware, data is wonderful, but typically it's anywhere from 3 months to 6 months behind. So we're just getting our data from early on in 2019. So we're starting to analyze that, and I've been able to look at our length of stay data. So on our End PJ paralysis units over the 6 months, we've seen a decrease in patient length of stay anywhere from a half day to 3.5 days compared to the same time range of the previous years. And this is all age groups, all unit types, and all patient populations. So not surgical or medical, all combined. But I've been able to look a little bit deeper. So specifically those patients over the age of 65 years, we saw a reduction in length of stay up to 7 days compared to the same time frame in previous year. So looking at how specifically on our medical units, we've actually increased capacity to those areas and saved a whole bunch of bed days, which is wonderful for not only for a system issue and capacity, but also for patients too, if we can get them home earlier and safer. But I also wanted to note and to highlight that all units involved in the project saw a decrease in the length of stay compared to the previous year. So we've been seeing, positive impacts on every single area that's been undertaking the End PJ Paralysis unit. People wanted to know, okay, Paul, that's really cool that you saved length of stay, but have patients been pushed out and are your readmission rates higher? So I wanted to look at the 7-day and 30-day readmit rates. So that's what you're seeing here. So if you look at the pre and post, and the numbers are small, but it does show me that we are seeing a small amount of patients that have not gone back to the hospital within 7 days. So that's what I like to see. I didn't want to see the inverse of higher numbers with readmission rates. So a small scant percentage of change overall with the 7 days. And if you look at our 30 days, we're seeing a little bit more positive reinforcement where less patients are going back to the emergency room. So anywhere from 10% to 6.1% pre and post interventions, around 7% to 5%. So seeing a decrease in the readmit rate to our emergency departments or to our hospital with the units that are involved in this, which is wonderful to see. So what's next from a data perspective? And as I shared, it takes a bit to get data from either our CIHI or our own data sorts. So that's something I'm going to be looking at, doing length of stay readmission for all of our pilot units. So there's about 16 of them now. So combining those and doing a report up to our leadership. I also want to look at fall rates pre and post. And being in a rehab setting, I knew that falls are actually higher in some of those areas. So I'm curious if our rates will go up or down. And I have a hypothesis that our rates might slightly go up more because of just the focus on getting everyone up and out of bed. So I'm interested to see how that comes through. The most important piece about that falls rate is, have we seen a decrease in incidence of severity of harm? So even with an increased rate of falls, are we seeing a decrease in harm? So that's something I'm keen to look at. Pressure ulcers are really important to many organizations, as I alluded to at the top of the call. It's key to understand how costly and how traumatic pressure ulcers can be. So we're going to look at those as well, and blood clots too. So these are some of the interventions and measures that our colleagues in the National Health System in England were looking at too. I think we get caught up in a lot of corporate data, and sometimes we forget to think about what about the patient side of things, or the story piece. So I wanted to also bring in our data set what the patient experience was with this, and in the same systematic way we used our dashboard to display our data, and we developed a list of 7 questions for patients and families using electronic survey. And we actually did not want to burden our staff by doing these surveys, so we enlisted volunteers. And our volunteers came up and completed, it's about 400 surveys now as of this morning, with patients and families that have undergone End PJ paralysis on their care unit. So using the volunteers to support this has been wonderful. And also I'm going to break these down for you that you can see here. So I spoke to promotional materials a few minutes ago, but if you see that top box, typically we think, oh, it's nurses and physicians and allied health colleagues that really share and spread our messages. And I think we overestimate that. Because those care providers are doing so much that oftentimes they don't have the full ability to share and spread and scale all about the initiatives. It's part of their assessment, but not always part of the communication to patients. So we've actually found that our promotional materials and our volunteer supports have actually spread and scaled our messages more so than any of our other allied health or nurses or physician groups have. So it's really important learning for me to take on when I think of other initiatives that we can do, or to even further some of our PJ paralysis activities. The bottom graph is just showing what I thought to be true is the bulk of our care is provided to those kind of 65 or older. And again, for PJ paralysis, we know that a lot of those target groups for deconditioning are 65 or older too. So it was just a relative sample. If you look at the top box score, and my colleagues in the data analytics world would say top box can be aligned with any positive outcomes past the neutral piece. So that would be someone agree and strongly agree. So if you look at the top box scores, we're just under the 90 percentile to say that patients feel that this has positively impacted their experience in hospital. It's encouraged them to get up and moving. It's made them more comfortable at getting dressed compared to what their previous or their thoughts on getting dressed would be. And it's made them more likely to get out of bed because they're dressed and they're more comfortable and they feel like they actually have permission to do so. So we know it's making an impact on our patient's stay, as well as their experience while in hospital. So here's some of the qualitative comments that we garnished, and I wanted to just share one, the bottom one. I think it's so powerful. It's a poster-worthy quote. Getting dressed every day is moving is a gateway to independence, self-fulfillment, and overall better health. So that was one of the quotes that our patients left with us, that would have been involved in the initiative. So I'm going to roll to another poll here. And after hearing about some of the work that in Alberta, what do you feel is the biggest myth that we need to bust for the public? And some of these were kind of afterthoughts. So is it that hospital gowns are sterile? Gowns need to be worn after every surgery to prevent infection. I can't wear my gown, or I can't wear my own clothing because I'm on isolation precaution. Staying in bed is an important part of my recovery. Or End PJ Paralysis is for everybody. So take about 10, 15 more seconds and we'll do that. And then we'll move on to kind of the last piece of the presentation this afternoon. Okay, so if we could close the poll. Perfect. And I agree. That was one of the biggest myths that we had with patients. So our group here today has said staying in bed is an important part of my recovery. And I think that is something that we need to be mindful of. I think patients feel when they're in a hospital that providers don't want them to get out of bed, that we want them to stay. It's about rest and healing and as much sleep as possible. And at times that is so pivotal, but that shouldn't be the only piece of a hospital stay. So how can we focus on that deconditioning piece? One other big myth that I was so surprised was the public feels that hospital gowns are sterile, and that was something that was really interesting to me. And I think that was something I had to really address early on, to let people know that hospital gowns are washed and laundered in the same process that you would wash your own clothes at home. So I just wanted to make people aware of that, especially the public. And some of the interviews I've done on media and radio, that was one of my key messages for that upstream, to make people aware of that hospital gowns are not sterile. So the last piece, just wrapping up here, what we learned along the way, really not to be prescriptive. Think of those care areas. This does not need a policy or procedure. And we need to shift that perspective away from that prescriptive practice. So getting patients in their own clothing and getting them up and moving does not have to be a stepwise approach. You can be unique. Each care provider can support it and work with the patient to get the best optimal ideas on how we do that. It kind of makes me think of an Institute for Healthcare Improvement initiative that Don Berwick spearheads, called Breaking the Rules for Better Care. So in a way, we're not breaking a rule, but we're providing better care by getting patients up and moving and doing things in a bit of a different way. You're probably wondering why I have a flag of the United Nations, but to be honest, I see each care unit we work with as its own country within a larger health system. So yes, we fly our organizational flag, but each unit program portfolio does not operate the same. The manager, the leadership, the charge nurse, the colleagues, even the patient population really drives care, whether we like it or not. And a one-size-fits-all approach really doesn't work in a health system. And that was very true for End PJ Paralysis. So we wanted to ensure that Frontline Teams had a say, and we were able to scope and shape what this looked like. Have fun and brand your work. So one of those key lessons, when you see things, that memory of recognition of, oh yeah, I need to get up and dress. And this is something that when we've talked to our patients about with their surveys, they absolutely recognize the poster. To be honest, the End PJ Paralysis word, from time to time, they're like, oh, I'm not sure what that is. I think paralysis gets them caught a little bit. But when you say getting up, get dressed, and get moving, they're like, oh, yeah, like that cute little character out front, or yeah, that large cardboard cutout. Yeah, I brought my bag. I have my clothes here. So that importance of visual recognition has been wonderful. And as I showed earlier, it's been a key piece for our awareness with the teams. Social media is something, to be honest, I wasn't comfortable with for a while to use in my work setting, but, I was supported and really mentored by Brian Dolan to use social media to spread and scale. And it's been a wonderful, wonderful adventure. It's allowed me to connect with my professional college, the College and Association of Registered Nurses. We did a wonderful spread in one of their care magazines. Our licensed practical nurses, I did a webinar for them and spread and scaled across to their members. Supporting with Canadian Foundation for Healthcare Improvements, having a chance to speak at a National Engagement Network meeting, working with our health quality councils in Alberta and Saskatchewan. It's just been so wonderful to see that. You need to make it fun. It has to have some meaning to frontline staff. It can't be the same old thing. So look at how you can provide the fun in it, whether it's something like creating an amazing race that's focusing on PJ paralysis, getting creative and thinking about your population. So an initiative that my colleague Emily Post is working on called Walkers Gone Wild. And it's about getting patients up and moving in a long-term care setting, but actually decorating their walkers or their wheelchairs so they have that visual recognition, the cue that, hey, that's my walker. And so patients can ambulate safer. And they're also actually seeing something I didn't even think of, but they're decreasing social isolation because patients and families and visitors are actually stopping and commenting on these walkers and wheelchairs and striking up conversations to let people know who they were and what they're about themselves. Try to connect this to other initiatives in your organization. Don't make it a new thing. Make it something that's there already. And Accreditation Canada comes to mind when you think about pressure ulcers and venous thrombosis and falls. So is there any other aspects like the MOVE initiative that I know is happening in Ontario? How can you align the same principles and market it the same way? Because a lot of the outcomes are identical. It's just a different catchy way. So don't start something new if you don't have to. I think your staff engagement will really spike and peak with that. Lastly, celebrate every tiny victory. I think it's really important because we don't give kudos nearly enough to our frontline teams. Staff will only try so hard before being recognized. So use things like social media to support victories. Have kind of those touchdowns to show, wow, look at this. You are making a big difference on our patients. Invite patients to come back to the unit to talk about how the staff have made a difference in their life. Those are the things that will really make a difference on your patients, on your staff, help morale, and even kind of continue with that. Again, this is just for the slide deck, but we've been fortunate to highlight some of our patient stories on CBC, CTV, and Global, and even some of our radio shows and the Globe and Mail as well. So I'll leave these here for you to check out and to highlight within some of the decks, and you can share that with the team. So I will now look for any questions, but I just wanted to close off by saying thanks for your time today. It's so important to chat about how deconditioning and PJ paralysis can make a difference on patients and families. So little by little, I feel a little becomes a lot. So I wanted to be open and honest with no budget, no assigned people to do this work. We've shown that a grassroots initiative still has a place in healthcare. So I wanted to thank you for your time today and open the mic up to any questions. And I'll just put up any of my contacts here if you're interested. And if we don't get your questions today, or if something comes up a little bit later, please feel free to always reach out. I'd love to chat with you.
Thanks so much, Paul. So many wonderful lessons and important points that you shared with us today. I'm going to encourage the audience now to start typing their questions in the chat box. And there's some that are coming through already. So one person has asked, how did you measure the mobility rate? And they also wanted to offer congratulations on a great improvement and change in practice.
Yes, thank you. So the mobility rate, we struggled with this, right? I'll be honest. What does it mean to mobilize? What does it mean to, prevent deconditioning? Is that 2 steps? Is that, 10 meters? Is it, doing specific, interventions? So we contemplated how are we going to measure mobilization? And for us, and one of our units actually was a spinal cord injury unit, and we knew we had to be mindful of all patient populations, not just those patients that can ambulate. So we really focused on getting them out of bed. So if a patient was up and out of bed, that was mobilized, depending on the care area. So going back to not being prescriptive, if it was a spinal cord injury unit and up to wheelchair, to me that is equally as important as ambulating. So getting their, the lung volume recruitment piece up and going and their circulation. But on those areas such as surgery, we really focused on, getting them up and moving and walking and ambulating independently or with a supportive device. So, we weren't prescriptive with that piece. And that's something that, if we are going to do further studies, especially research or not quality improvement studies, I think we will set a limit around how many times a patient's up a day and how far they're walking to see if those actual measures are making a difference in further length of stay and decreasing things like falls and pressure ulcers and things like that. So great question, but we were fairly general on that description.
What a great answer, and a good point too, that there's a big difference between quality improvement measures and measures that you would collect for research. Another question that's come in about noticing high decline to get dressed rate on one of your data slides, and wondering if you had any more information behind that. Was there a certain barrier, staff, etc.? Is there a lesson learned on that one?
Sorry, I was on mute there. I'm just going to go back to the slide that shows that so I can comment specifically to that. So hopefully I'm not making anybody dizzy here. Yeah, so we have a decline to dress rate of about 20% on this one area. And this is the South Health Campus, Unit 58, which is actually one of our transition units. So their patients, a large population of them, are waiting for long-term care. And I think they also have secondary neuro diagnoses as well. So they have behavior issues, brain injuries, things like that, that's, you know, a part of their care plan. It might not have been that time where they do get patients up and dressed. So that is one reason, not to make excuses for this group, but their population has a high tendency of you know, I guess, physical violence as well. So that's something I think that the staff safety piece came into, where declining to dress or declining to mobilize might have been there. And I am happy and proud of this group because they do have a high decline to dress rate, but they still have, you know, scaled that down by about 15% to get people up and moving. So that is one of the positives.
Great. A question here about why did you choose the NHS in England? Are there other countries that are trying to end PJ paralysis?
Yeah, great question. I think, you know, at the time, the National Health Service is a leader in so many ways, but the connection that they had with Brian Dolan, their 70-day challenge to have, I think they wanted to have 800,000 patients dressed up and moving in that 70-day period. So that connection with Brian, the openness with the NHS to share, my involvement on social media with their groups to beg, borrow, and steal all their successes and their interventions and see how we can make that happen in Alberta was one of the reasons why we aligned ourselves so closely with the National Health Service. But recently, and I'm not sure if some of you are aware, we've just completed a global summit for End PJ Paralysis, where we had over 21 countries participate across 3 straight days. So we started in Australia and started New Zealand, Australia, with the time zones there, moved over to Europe and the UK, had a bit of a break, and we rolled into North America, where John Hopkins and Alberta Health Services planned the North America aspect of it. So we did 3 straight continuous days with the different time zones of PJ Paralysis presentations, and those can all be found for free, recorded on the Health 60 webpage. But if you actually go into any internet browser and type in End PJ Paralysis Global Summit, that will take you directly to that site. All of those presentations will be there for a full year. So it's a great way to see what other countries are doing, even, you know, in the US as well. John Hopkins is a huge leader. They talked a lot about the research around mobility. So I would encourage you to do that. And those are some of the reasons why we picked the UK, but also, you know, it's now becoming an international initiative too, which is great to see.
Wonderful. And that answer actually leads into a couple of other questions about where folks can get more resources. They're wondering if you have any that you can share specifically, including the slide presentation.
Yeah, I'd be happy to if groups wanted to reach out. I am almost at the point where we have our public page within Alberta Health Services. We just completed our internal page. So we have what's called an intranet, which is any staff member can access it. So we built that all up. And being a part of a provincial organization is wonderful, but it also has some challenges. So we had to follow branding standards. And a lot of the things that we created in the unique way had to be, you know, validated for language, validated for our branding standards in AHS. And actually, since we made so much waves and headway, we were able to commission an artist to provide 5 new sketches for our campaign too. So we're able to spread and scale. So those resources will be available on our AHS external page in a couple weeks. But if you wanted to reach out to me internally, I'd be happy to share and scale any of our educational information brochures as well. And yes, please check out Health 360 website and even just putting in NPG Paralysis Global Summit. There's some amazing resources, anywhere from how to brand your initiative to, you know, looking at interventions on like Berg balance tests and things like that, and how PJ Paralysis can make a difference. So it's great.
Great, thank you. That's very helpful. One final question here. How did you shift mindset of staff about needing a gown due to wounds, IV therapy or IV lines, cardiac monitoring, emergency treatment access like CPR?
Yeah, that's a great question. This comes up quite a bit, actually. So, in some of our areas, such as like CVICU, where we do have, open, large open wounds due to open heart surgeries and things like that, then we've taken the safety approach. If there's no possible way to get patients up and dressed and moving, it's not part of their care plan, then we've tried to support that piece around the safety. But in most cases, such as a simple IV, we have to thread that IV through the gown anyways. So it's as simple as threading it through the t-shirt. It might take a few more minutes, but at the same time, there's a lot of teachable moments there. A lot of people push back about Foley catheters as well. And one of my colleagues, she's actually a quadriplegic, and she said, I've had a Foley catheter for 30 years. I live in the community by myself with my son and my husband, and I would have been like really sad if I wasn't allowed to wear my own clothes, because when I got home, I would have had no clue what to do, how to take care of my leg bag, how to hide it, how to prevent leaks and things like that. So there are really teachable moments. It's not for everybody, as I shared. There are care experiences that we have to be mindful of. And we also tell patients to, don't bring your best clothes, because they potentially could get stained. If you have a leaky wound, be prepared that you might get some exudate on your shirt, or in times of emergency, we might have to cut things off the same way we would in an ambulance or in the emergency department. So, just I guess my whole overarching philosophy is being very open and transparent, allowing the patients and the staff to come to a conclusion: is this the right thing? And if clothing ever is a barrier, as I stated, then just still really focus on that deconditioning piece, because we'll see the values there. And when care starts to step down, where patients are becoming less supported on technology and lines and machines and things, then start to incorporate that clothing piece as well.
Great. I don't know if this is a quick answer, but there is one final question about, do the folks at risk management know what you've been up to? Laugh out loud. Wondering how you might have engaged those folks.
Yeah, I think we've taken a fairly, I guess, cumbersome approach to risk. One of those, that first tri-storming event was looking at the risk to staff and to patients. And I think we've tried to check as many boxes as we can by listening to those frontline concerns, such as washing of clothing, infection prevention, DI, even those general safety concerns as well, such as elopement risks. And, we don't want to put people at risk for anything we are going to support them with. So yeah, risk management has been a big piece, but at the same time, I think going back to that same message, it's really up to it's really a patient choice, and it's our expectation to support them with that. And if there is something that we see as risky, I would wholeheartedly say push the stop button. We don't want to put patients or staff at risk when we're doing this initiative. So, if you're encouraging a family member to be a part of their care, but they're trying to walk their loved one that can barely stand, that's where you step in and say, no, like this, we can't support this. Even though we're trying to get your loved one up and moving, it shouldn't, we don't want to put you at risk, the patient or the staff at risk too. So it's that mitigation piece. It's not so much as common sense, but really about mitigation.
Wonderful. Well, thank you so much, Paul, for this great learning opportunity. I know that this information will have inspired attendees to think about mobility at their organizations in a slightly different way. We want to also encourage attendees to use the free mobility resources that we have on our website as well. We have learning modules, posters, patient handouts. I know some of you were asking for extra resources. And we want to thank everyone for attending the webinar. You'll receive a short evaluation survey by email, so please share your suggestions on topics for future webinars with us. And our next webinar, we'd like to invite you on September 19th, where you'll learn more about the Senior Friendly Caregiver Education Project with Sarah Gibbons and Susan Bask from the Regional Geriatric Programs of Ontario. And we'll be sending registration information shortly. Thank you again, and we'll see everyone next time. We're signing off now.